Hi, my name is Gabby O'Leary.
And I'm Lia and Gabby.
And we're going to be presenting on cardiovascular disease, specifically congestive heart failure.
Our objectives for this presentation are going to be to describe the cardiovascular system, explain and provide a thorough cardiovascular assessment and what findings would be concerning, describe important history related to cardiovascular disease, and discuss pharmacological therapies, procedures, and self-management for cardiovascular disease. The cardiovascular system is made up of three components: the heart, blood, and the blood vessels. And the heart is truly like the main powerhouse of the cardiovascular system. The heart has many different components to it. It has two atria, two ventricles, an aorta, superior and inferior vena cava, the pulmonary arteries, the SA nodes, and the AV nodes. Next, we're going to move into the cardiac functions. So we have the cardiac output, which is the volume of blood pumped by the heart in 1 minute. So to find the cardiac output, you need to take the heart rate times the stroke volume. The stroke volume is the amount of blood pumped in by the heart in one heartbeat. From there, we're going to talk about the preload and afterload. Preload is the amount of blood in the ventricles after the heart contracts, and afterload is the pressure of the left ventricle that it has to push against to overcome the contraction. Ejection fraction is the percentage of blood pumped out of the ventricles with each contraction. And that's something that we measure a lot of the times in the cardiac patients. And that would be measured by an echo. And that's something we'll talk about in a little bit.
There are multiple types of heart failure that we discuss in more detail on the next few slides. Right-sided heart failure is characterized by the right ventricle not pumping properly, causing deoxygenated blood to not reach the lungs. The blood backs up into the veins, which causes increased pressure in the veins. The increased pressure causes blood and fluid to leak out into other tissues of the body, which is called swelling, which is also known as edema. This edema is commonly found in the legs. Left-sided heart failure is actually the most common cause of right-sided heart failure due to the enlarged left ventricle pressing on the right ventricle and causing it to not function properly. Left-sided heart failure is divided into systolic heart failure and diastolic heart failure. Systolic heart failure is also known as heart failure with a juice ejection fraction because, as you may recall from earlier in the presentation, the ejection fraction is the force that blood is pumped out of the ventricles. Diastolic heart failure is known as heart failure with preserved ejection fraction because the force is present to pump out the blood, but the amount of blood is lower due to the ventricles being stiff and not relaxing to allow the proper amount of blood to be ejected from the ventricles. There are a variety of conditions that can lead to heart failure: diabetes, coronary artery disease, previous myocardial infarction, severe lung disease such as COPD or emphysema, hypertension, obesity, tobacco use, sleep apnea, and congenital heart disease. We will discuss some of these conditions in more detail in the next few slides. 70% of heart failure patients have coronary artery disease. As you can see in the picture on this slide, plaque builds up in the arteries, often due to fatty matter, and can lead to blockages, which leads to scar formation, causing the blood vessels to narrow and have to remodel. The narrowing of the blood vessels causes the heart to not relax properly. Hypertension is a common risk factor for coronary artery disease and heart failure patients. Vascular resistance is increased, which then causes the afterload to be increased, causing the left ventricle to need more force to eject the blood, which we've talked about a bit in this presentation already. The left ventricle also increases in size and stiffens. All right, we have a question for you to think about. Have you ever cared for a patient with heart failure? Think about some of the symptoms they presented with.
When going into a comprehensive physical assessment, you want to look for multiple things for these patients: shortness of breath, which could indicate fluid in their lungs; edema, which could indicate fluid in their legs; weight gain, fluid anywhere in their body; fatigue, anxiety, diaphoresis, cough, chest pain, chest palpitations, jugular vein distension, and an increased heart rate. You can also tell a lot by the patient's vital signs if they are having a heart failure exacerbation. Their blood pressure might be higher, respiration's higher, and also some tachycardia. When you're listening to the patient's heart sounds and their lung sounds, their lungs can sound like crackles due to all the fluid in there. This could also cause their shortness of breath. Some extra heart sounds are also heard, like murmurs, due to an increased blood flow and the valve not opening and closing correctly. S3 is the most common heart sound that you will hear in heart failure patients. This is heard when there is a rapid filling of the ventricle and the ventricle is not expanded to accommodate all of the blood.
Another part of the detailed physical assessment is an electrocardiogram, also known as an EKG. Heart failure can cause patients to be at higher risk for dysrhythmias and ischemia due to the heart not allowing blood to flow to the rest of the body properly. An EKG can be used to detect arrhythmias and ischemia by placing electrodes on the patient's chest to detect their heart rhythm. The rhythm can tell us many things about how the heart is functioning, including ischemia, which indicated damage to the heart muscle, causing poor blood flow, such as in myocardial infarction, which we listed as a possible patient history for patients with heart failure. Another diagnostic procedure that is often used to diagnose patients with heart failure is called an echocardiogram, also known as an echo, where a Doppler ultrasound is placed on a patient's chest to show blood pumping through the chambers of the heart. This procedure can show the overall function of the heart and can also measure ejection fraction, which we previously talked about in this presentation. A normal ejection fraction is 50 to 75%, and borderline is 41 to 50% for heart failure patients.
Another really cool thing about echoes is that they can look at the heart and see if there is a hole in the septal wall. So we can do a bubble study, which is agitating two syringes of fluid, causing some bubbles in there, and you'll put it in through the patient's IV, which sounds very contraindicated because we never want to put air into a patient's IV, but it will go into the patient's heart and you'll be able to see the bubbles. It'll get a little bit darker gray, and then you can see if there's a hole as it shifts through the ventricles.
Here's an image that kind of illustrates ejection fraction more. The ejection fraction compares the amount of blood in the heart to the amount of blood pumped out of the heart. The fraction or percentage describes how the heart is pumping blood to the rest of the body. Like I discussed in the previous slide, a normal ejection fraction is 50 to 70%, which is pumped out during each contraction. Borderline ejection fraction would be 41 to 49%, and then a reduced ejection fraction is anything less than 40. And it's also possible to have a heart diagnosis of a heart failure and also have a preserved ejection fraction, which we discussed earlier in this slide.
Another diagnostic test is a coronary angiography, also known as a cardiac catheterization or a cardiac cath. X-ray contrast is inserted into the artery either through the groin or the vein and sent up into the heart, and then X-rays are taken of the patient's heart. This will show us if they have any blockages or damages in the heart, and a lot of patients with heart failure often do have damage. If you look at the top picture to your left of the screen, you'll kind of see the heart. The blue in the middle picture, there is a blue wire going through there, and that is called a guide wire. It'll go in there and they can insert a stent through there if they find a blockage. They can also balloon the area, so they quite literally just fill up a balloon and push all the plaque to the sides. And they can also do what's called kind of a rotor-rooter, so they can go in and kind of break up all the plaque in there if there's a lot. The bottom picture there is the inside of a cath lab. The patient will lay on that bed, and that little C arm comes over, and that's the X-ray machine. It'll sit over top of the patient's chest and take the pictures while the cardiologist is on the side of the patient, kind of advancing the wires. They will have the 4 TV screens there so they can see the patient's vital signs and also see the images that they're taking and where their wire is going. The intervention of placing a stent is called an angioplasty. So the picture here is showing what the stent looks like and the balloon inside the stent as it's getting inflated inside of the patient's artery. This is always done in the cath lab, and you can place multiple stents kind of back to back to each other, and this helps keep the blood vessel open. There are drug-eluting stents, which will constantly let go of an anticoagulant to kind of help keep the stents open. And those are most commonly used.
Patients in acute exacerbation of congestive heart failure often present in respiratory distress due to the reasons we discussed on the previous slides, due to fluid being in their lungs and hearing the crackles in their lungs, causing them not to breathe properly. We often use non-invasive ventilation support through a CPAP or BiPAP. In the hospital on my unit, we often use a BiPAP for acute exacerbations. As you can see in the picture there, that's exactly the type of BiPAP we use, and it's giving them pressure support as well as oxygenation. They can turn up the what's called FiO2 to give them more oxygen if they happen to be desaturating from not the blood not getting the oxygenated blood in the body not getting to the rest of the body properly. So it improves their oxygenation, will help reduce the cardiac load, and will increase cardiac output to help patients breathe properly. Like we mentioned before, in patients with congestive heart failure, arrhythmias may develop. One of the procedures we can do is a cardiac resynchronization therapy or a biventricular pacemaker. This pacemaker detects irregularities and helps regulate ventricles to beat in unison. It also helps increase the blood flow. Patients who have ejection fractions of less than 25% often receive pacemakers or ICDs, which we'll discuss on the next slide. An ICD is another device that is often placed in heart failure patients to detect dangerous arrhythmias, such as ventricular tachycardia and ventricular fibrillation. This device provides an electric shock to the heart to help it restore a normal heart rhythm. And some of these pacemakers, or some of these ICDs, have a pacemaker feature to help regulate the heartbeat. Like we mentioned before, many heart failure patients also have coronary artery disease, so they often require a coronary artery bypass to reroute their blood flow around their blocked blood vessels. A healthy blood vessel is often removed from the leg of the patient and attached to the blocked artery. This will help reroute healthy blood through the healthy blood vessels and around the blocked blood vessels.
Valve replacements are a common procedure that are done for patients with heart failure. The first one here is least invasive. It's called a TAVR. This is when they go in either through your groin, or they can go via subclavian approach, at least at the hospital that Gabby and I work at. So this is when they take a new valve and they will feed it up, kind of like a cardiac cath, through a catheter, and then expand that valve within the aortic valve. This will then take the place of the aortic valve because there is so much stenosis, and help the blood vessels go through there and create less resistance. There's also a aortic valve replacement that they do a full open thoracotomy. They'll go in there and replace that. That can be either a cadaver valve, or we have used pig valves in the past. And then there is a mechanical valve, as you see in the fourth picture here. This valve is pretty cool. It's all metal, and you can actually hear a clicking sound. It sounds like a wristwatch clicking. You can hear it whether you're just standing next to the patients or with a stethoscope. So the reasons they would get this type of valve procedure is that it helps regulate the blood flow and prevent backflow into the heart. If damaged, the heart does not pump properly. TAVRs are kind of the go-to procedures because they're less invasive. And in some cases, they are considered a palliative procedure because the patients are a little bit older when they get these procedures. Another really cool device to treat heart failure is called a left ventricular assist device, or an LVAD, or the ones that Izzy cut in Grey's Anatomy. So this is a machine that goes in and it basically pumps your blood for you. You'll have an incision in through your abdomen, and then a coil that goes up through your stomach, and then your heart will have a machine that pumps all of your blood. Your heart will not be pumping. And it is quite literally you're a machine person. You have about 30 seconds before the battery dies when you're changing it. At night, you need to be plugged into the wall so the battery stays charged. And this is really used for patients who need a heart transplant. It is known as the bridge to transplant. It's a completely surgical device that is inserted, and it is used for a long term in patients who need a heart transplant. The next step for patients with heart failure after an LVAD is a heart transplant. This is for severe cases of heart failure. It is a last resort when no other treatments medically or surgically have helped. It's a completely open heart or open thoracotomy procedure. Survival rate is 90% after 1 year and 80% after 5 years for most adults. While the patients are going through surgical interventions, or even after their surgical interventions, these patients are going to be on a lot of medications. Some of the medications that they will be on would be ACE inhibitors, such as lisinopril. ACEs help to relax the veins and arteries to lower the blood pressure by preventing the body from producing angiotensin II. Angiotensin II inhibitors, or ARBs, like losartan or valsartan, are medications that allow the arteries and veins to dilate to also reduce the blood pressure. A lot of patients are going to be on beta blockers like metoprolol, atenolol, or propranolol. These are medications that can help prevent any dysrhythmias for the patients. And they're medications that help block the epinephrine, which can lower heart rate and blood pressure. Diuretics are going to be huge for these patients, as we talked about having shortness of breath and edema, weight gain. These medications are going to be furosemide, spironolactone, metalazone, and 100 of other ones that we've probably worked with on a day-to-day basis. These medications are going to help the kidneys produce more sodium and therefore help pull the excess fluid out of the body, so the patient can help excrete that extra fluid to help their breathing and reduce some of the stress on the heart. A lot of these patients are also going to be on blood thinners like Coumadin or warfarin, Eliquis, Xarelto, Plavix. They get a different medication of blood thinner medication based on like what procedure they had or if they've had a stent placed. These are going to help make sure that their arteries stay clear from plaque and they don't have all of this buildup to cause a blockage. And lastly, anti-cholesterol agents like Lipitor are going to help patients by reducing their cholesterol and the plaques that may build up in the arteries. So I have another question for you guys. Which labs are especially important to monitor for patients with heart failure? If you're thinking about all of these meds that we're giving them, what do we really want to be watching? It is something we'll talk to you about here in the next slide. Labs are going to be extremely important for these patients, especially with some of the medications they're going to be on. If a patient is on Coumadin, we're going to want to check their INR and make sure that they're between a 2 and a 3 on that scale to make sure that their blood is thin, but not too thin or not thin enough. A BNP is also important for these patients. It can assess if the patient is having a heart failure exacerbation and to what extent they're having this exacerbation. Troponin, this is an enzyme that is released by your heart, and it can tell us if there is a blockage anywhere in the blood vessels. Potassium is going to be really important to watch in these patients, especially the ones taking diuretics, as with all of the peeing that they're doing and excreting of fluid, they can pee out this potassium, and then their potassium can get low, and in turn cause dysrhythmias and other heart problems. They also are going to be watching lipid panels. This can assess their cholesterol and assess the risk of patients getting occluded arteries. Cardiac rehabilitation is an important part of the process for the patient's healing after procedures or surgeries of their heart, whether it's open heart surgery, a TAVR, a cardiac cath, or a mild heart attack where they're just medically managing the patient. These programs are exercise programs and education programs that the patient will go to 2 or 3 times a week, especially at the beginning, and then they can graduate to phase 2 and 3 and 4. These are times where they'll sit down with a trained cardiac rehabilitation nurse or therapist, and they'll talk about how their lifestyle changes, how they need to change their lifestyle. They'll perform low-impact activities like walking, cycling, and rowing, and education like their diet, quitting smoking, and lifestyle changes. Self-management is talked a lot about during cardiac rehabilitation and then discharge from the hospital. A lot of our patients will go home with a heart failure zone tool. So the green zone is you're all clear. You're not having shortness of breath. You're not gaining weight, no swelling in your feet, ankles, legs, and no chest pain. The yellow zone is kind of when you should probably start calling your doctor. You're having some weight gain of more than 3 pounds in a week, or 3 pounds in a day or 5 pounds in a week, increased swelling in your legs, shortness of breath when you're walking, dry, hacky cough, dizziness, shortness of breath, and just kind of an uneasy feeling of something in your body just doesn't feel right. And then red zone is when you need to call 911 or get to the emergency room. You're really struggling to breathe. You're having chest pain, unrelieved shortness of breath while you're just sitting, and then confusion and inability to think clearly. These patients might also be on a fluid restriction. Often it's going to be a 2-liter fluid restriction per day. They're going to be on a low sodium diet because if they have too much sodium, they'll retain more fluid. They're going to keep a chart of their weight, their blood pressure, and their heart rate, limiting their alcohol, and we're really going to push these patients to quit smoking. They also want to know their baseline activity and kind of make sure we're getting back to that. And then we're going to have these patients really focus on stress management. The increase in stress that they have is going to put an increased strain on their heart.
All right, so we created a little case study to have you apply the information that you learned during our presentation. So Jim presented to the emergency department with some shortness of breath. The patient reports he has gained 15 pounds in the last week without changes in his diet. What medical history as the nurse would you want to know about Jim? All right, so as the nurse, when you're asking Jim about his medical history, he mentions to you that he has a history of heart failure, a previous myocardial infarction, as well as a history of atrial fibrillation.
So after hearing Jim's chief complaint and his medical history, what assessment findings would you expect when you're assessing Jim? So while you're assessing Jim, you hear coarse crackles in his lungs, you see +4 pitting edema in his lower extremities, shortness of breath on exertion and at rest.
After assessing Jim and attaining his vital signs, you notice that his SpO2 is 78%, his heart rate is 142, his blood pressure is 164/88 at rest, and his respirations are also 34 at rest. What would be some of your next nursing interventions for Jim? As a nurse, you would expect to call the doctor for an EKG to assess his rhythm to see if his heart rate is just sinus tach or possibly a different arrhythmia. You would anticipate some diuretic orders to help get that fluid off of his lungs, and you would expect supplemental oxygen therapy, likely BiPAP, since his respirations are 34 at rest and his SpO2 is 78%, because that would help provide some pressure support and help increase his SpO2.
Thank you all for your time today. We hope that you learned a little bit about the cardiovascular system. If you guys do have any questions, please feel free to reach out or leave it in the discussion box.